I want to just say a few words about your perspective now, and then we'll move to the expert panel.
So Warren, you can take a break. You don't have to warn me about 5 minutes. That's all I've got. Hattie asked me to talk a little bit about our vision for what we call the Be There campaign, the campaign to make San Diego a heart attack and stroke-free zone. I put together some slides. I'll go quickly. I'll first say, as an editor, those are wonderful data, and there's about a few thousand potentially confounding variables, like the institution of a hospitalized program for myocardial infarctions and door-to-balloon time and whatnot. But nevertheless, we are fully prepared in San Diego to take credit for this. You can relax. We're more than happy to take credit. So this is the paradox of coronary artery disease, myocardial infarction, and stroke. And the paradox is that although the risk is highest in the high-risk group, the number of patients in that group is relatively small. So if you take a lower risk of a larger group of patients, such as in the intermediate group, you actually get a larger absolute number of events, heart attacks and strokes. So that in the past, we've all focused on this higher risk group, but it's clear if we're going to make an impact on heart attacks and strokes, we've got to go lower, and perhaps even as low as the overall population. And so that's the group that we wanted to address. Now, we don't know what causes coronary disease. We know the risk factors. Some are non-modifiable. We used to say gender was non-modifiable. I guess I'll have to remove that from the slide in this day and age. Family history, you don't get to pick your parents. You can't change your age or your history of coronary disease. There are some secondary risk factors related to lifestyle, the most important one of which, overwhelmingly, is tobacco. And then there's the risk factors that have been heavily quantified, particularly elevated low-density cholesterol, elevated blood pressure, to a lesser extent triglycerides. So we know there are risk factors, and the question is, if we lowered these risk factors, what kind of impact could we have on coronary disease? And so the first to address this, Drs. Walden Law in Great Britain, published in the British Medical Journal, they took evidence from scientific studies about interventions directed toward risk factors. And they took that evidence and they said, what if we applied that in a preventive program? So they looked at the evidence for reducing events by lowering LDL with statins, by lowering blood pressure, by reducing platelet function with aspirin. And as a composite, they published data that, in fact, if you did all of these things and you did them effectively, you could reduce the number of heart attacks by 88% and the number of strokes by 80%. Pretty impressive. Now, can this be true? Salim Youssef, a very esteemed investigator, and colleagues did the same exercise with a little bit different intervention. They put in beta blockers as well and left out the homocysteine. And they calculated a composite reduction of about 75%. And so, of course, sooner or later is a meta-analysis that takes all the data, and the results are that if you take a full-dose poly pill containing all of these, that based upon documented evidence, you should be able to reduce heart attacks by about 70 to 80% and strokes by about 65 to 70%. So we had evidence that, number one, we knew what the risk factors were, number two, that we could reduce those risk factors, and number three, this was a bit theoretical, that by a tremendous reduction of risk factors, we should have an extraordinary reduction of events. And so that generated Right Care, what we now call Be There, and I'll tell you why in a moment, our project in San Diego. And Hattie, Liz, lots of people, a good idea has many, many parents. A bad idea turns out to be an orphan. And this one works so that there's a lot of parents. In any event, we said what we've got to do is we've got to get patients to get screened and to adhere. And what you saw in that survey we just took is that all of us recognize that the patient ultimately is the most important step in any of this prevention. If they won't present themselves and they won't adhere to therapy, then nothing else counts. And then we had to mobilize the providers. We had to convince them that if they aggressively reduced risk factors, that they would reduce heart attacks and strokes. And there's lots of data that therapies of documented benefit are not always applied as they should be. So that's what we wanted to do. And so how do we get patients to present themselves and take care of themselves? And there's a wide literature on this, but virtually everybody who studied this agrees that there's got to be an emotional tug. That if you just present facts, you can present them over and over again, and without an emotional tug, you're not likely to change behavior. So we said our emotional tug would be to convince people, potential patients, that they should take care of themselves, not for themselves, but for loved ones, because there's lots of data that that's a powerful emotional tug. So we developed some material, as you see here, an African-American father dancing with his daughter at a wedding. It's her time to shine. Be there. Heart attacks and strokes are preventable. My own personal favorite is this one. You see, the father is somewhat ghosted out, playing chess with his son, ghosted out, having expired, and it reads, "Dad, you never let me win. Now I would do anything to have you beat me one more time." Emotional tugs to be there. And that was our pitch to patients. Now, what about mobilizing physicians? Well, that's the University of Best Practices, and you'll learn much more about that in the afternoon. I think an individual who isn't here but's been here in previous years who really deserves credit for this is Jerry Penso, who, and Jim, it came up with the idea. And the thing we've done in San Diego that I'm told is unique in all the world is that we've taken virtually every healthcare system and brought them all together. We all participate, Sharp and Scripps and UCSD and the community clinics and the San Diego Health and Human Services Department, Kaiser Permanente, the VA. You see all of these, the multicultural group, the American Heart Association. But it's amazing because all of these entities compete vigorously with each other in the medical community, but they've all come together at least once a month, leave their guns at the door, and work on a common goal to reduce heart attacks and strokes. I don't know of another community where that's been done. We've just received a telephone call from New York City, and the New York City Department of Health wants to know how we've done this, and I'm not sure I know, but anyway. All right, so this is my last slide, and Warren's already diaphoretic. I've probably gone over my 5 minutes, but what we did is we came up with this program, and we called it, our goal is to make San Diego a heart attack and stroke-free zone. Now, when we first did this, everybody said, "You're nuts. You know, that can't be done." And I just showed you it can't be done. If you reduce every risk factor, you're only going to reduce events by about 75%. But nevertheless, it's an audacious goal, and it catches people's attention. And we want to catch people's attention. And in the grant we've secured, through Kitty and with Christy and people that you'll meet this afternoon, we have a program where patients get screened and where they have a health coach, and we apply the Be There philosophy, and we hope to have some really advanced technology like wireless blood pressure cuffs. But part of this is a heart attack and stroke-free zone to make the community the owners of it. If the doctors are the owners, people are never going to be as incentivized as if the patients are the owners. So, you know, we have a very arrogant population in San Diego. We think we have the world's greatest city. We do have the world's best climate. There's no question about that. And so we can rally the community that way for patient activation. In terms of physician mobilization, we've got University of Best Practices. We've got all these groups coming together with a fixed medication bundle that reflects in large measure the preventive things I've shown you. Now, I don't know if all of this has produced a 14% reduction in heart attacks. Stroke's a little bit harder. It takes a longer time to reduce strokes with prevention. But as I said, I don't know if we did it, but I'm sure willing to take the credit. Thanks.